Welcome to the Menopause and Cancer podcast, where we speak with cancer patients, survivors, and incredible experts in their fields to help us find solutions to our symptoms and also find ideas to improve our health. My name is Danny Binnington, and today we're going to be talking about all of the gynecological cancers, whether you can have HRT and whether local systemic HRT or estrogen is an option for you. We have many conversations in our community, in our Facebook group, and people say, gosh, I've had a gynae cancer diagnosis. I feel like there's even less information out there for us ladies. I feel like no one talks about our different type of gynecological cancers. What are our options? Can I have HRT? Can I have local estrogen? And it really seems like that the cancer community in general is very excluded from the greater menopause conversation. And then within that, we have people that even feel less talked about, spoken about. There might be less research even. So I want to know what research, what evidence do we have for the use of HRT of the different types of gynecological cancers, and the same for local estrogen. And I'm really grateful that Mr. Vikram Talaulikar is here to teach on this subject today on this episode. He's a specialist at the Reproductive Medicine Unit in University College London Hospital, NHS Foundation Trust, and he's also the Honorary Associate Professor at UCL. It's amazing to talk to him because he runs a really busy menopause clinic at a busy hospital, seeing very complex cancer patients. And I want to know from him, when is the best time to scoop up a cancer patient after a gynecological cancer diagnosis? What types of treatment are first line? When do we resort to other options? And I really want to go through it list by list. We're going to work through the list. I hope this is really helpful and educational. And we know we have a lot of clinical nurse specialists listen to our podcast. I also hope this is really helpful for you so that you can continue to provide great care for your patients. So get pen and paper out. I hope this episode is super useful, and I can't wait to do a lot more around all of the gynecological cancers and symptoms and how we can provide help. I hope this is helpful, and let's get on with it. Hello, Dr. Talaulikar. How are you today?
I'm fine, Dani. Thank you so much for asking, and thank you for inviting on the podcast.
Oh, it's great. I mean, you have come onto the podcast years ago when we first had our first few sessions, and here we are many Wednesdays later, and we come out with these conversations. And you've been a real supporter, not just on the podcast side, that's a tiny bit of what we do, but really to help us stay evidence-based, get the right information out. You've just written a fact sheet for us on hot flushes, which has been so helpful and downloaded many times. So thank you for everything you do.
Thank you.
You run a very busy NHS clinic at University College London Hospital, and you see a lot of gynecological cancer patients. Tell me a little bit about your background as a clinician, and then also tell me a bit about your clinical work. Who do you see? What gynae cancer patients do you see?
So as you know, Dani, we have a big cancer and menopause service at UCLH, which is based at the Reproductive Medicine Unit. It was really a service that was started by my mentor and senior colleague, Miss Melanie Davis. And it basically, we see patients who have been diagnosed with any form of cancer, may it be hematology, may it be any other gynecological cancer, non-gynecological cancers. But menopause, of course, is one of the late effects of many cancer treatments. And so anybody who is thrown into menopause because of the cancer and its treatments, we will see them in the clinic. We'll try to provide support, whether it's lifestyle, non-HRT, HRT medications. My journey into this clinic happened as part of reproductive medicine. I was doing largely fertility and endocrine related clinics. But once I realized menopause is not being talked about much, it's not given the importance that it actually needs, that got me into these clinics. And even so, for women who've been diagnosed with cancer or treated for cancer and then facing menopause, as you know, and all the work that you've put in, the situation is not great. They need a lot of help and support, which is lacking currently. So in the clinic, we try to make sure that we can provide it to them, involving their GPs, involving their oncologists or specialists as much as we can, trying to give them kind of a multidisciplinary care. But of course, there are lots of challenges. I'm sure we'll talk as we go along. But that's really where my interest into menopause and cancer comes in.
Thank you for that. I recently spoke to a brilliant breast care nurse, and she said a colleague of hers would never refer her patients to a menopause specialist because she said all they would do is they can only prescribe HRT. That's incorrect, right?
Yes,
It's,
yes. I think that's
yeah.
probably just taking one point of view. Menopause is not
Mm.
HRT when there are many other aspects of treatment or menopause which need to be discussed.
Yeah, exactly. I recently hosted a series on HRT after breast cancer on the
Yes.
podcast. And I think one of the biggest frustrating things is people always say there's a lack of evidence and a lack of data and maybe not good enough studies and they're very old. And then I popped into our Facebook group and we had many messages from gynecological cancer patients saying, hang on a minute, if you think there is poor evidence for breast cancer, then look at us. I have no idea what my options are. And so can we talk about that in real detail today, please?
Yes, absolutely. And it makes it good timely sort of a podcast because this is Gynecological Cancer Awareness Month. And so really we'll talk today about what evidence is out there for gynae cancers. We'll start from the ovary, the endometrium, the uterus, the cervix, the vulva, vagina. We'll try to talk about systemic and local HRT and the non-HRT therapies, and hopefully provide a bit of an overview. Now, it's 1 hour, so I guess we have lots to fit in. We may not be able to go
Yes.
into every detail. And again, we're not providing individual advice because everyone has different stages, different types of cancer and menopause related issues. So, this is an overview, but we'll try to do the best we can.
That's fantastic. And we can always do follow-up conversations. I'm also going to hopefully record a follow-up with the EFA appeal. The nurses there have a hotline people can ring up. So I just want to really make sure people connect to the right services. So why is the menopause onset after gynecological cancer treatments? Can you talk us through that a little bit? Because that differs as well.
Yes. So I often say menopause after cancer is more challenging. And the main reason for that being whatever treatment gets you into menopause, it's happening very acutely. Women who have natural menopause, say after 45 or 50, will have their time as the hormones decline to get adjusted to these decreasing hormone levels. So they go through perimenopause, they go through menopause, and over the years, 2, 3, 5 years, there'll be less and less of estrogen, progesterone, testosterone. They will have time a little bit to get adjusted to these declining levels. Again, this is not to downplay natural menopause symptoms. Many women will have a tough natural menopause, but the cancer treatments push you into menopause quickly. So if it's surgery to your ovaries, it's going to happen in 48 hours, which is a huge hormone shift for women. You're going to be devoid of your estrogen within 48 hours. That's profound hormonal change. Then you look at the chemotherapy, you look at pelvic radiation, or some of the immunotherapies. Again, they can have some or other effects on ovaries. And if it's a strong chemotherapy or pelvic radiation, we know it's going to again cause you medical menopause. And that happens over weeks or months. This is much more acute than the slow nature of natural menopause. So many of the women who have these treatments, whether it's surgery, chemo, radiotherapy, or embolization or others, they will notice that the symptoms are sudden. They tend to be much more severe. They tend to be persistent. They last longer and more severe and frequent. That is why we often say these are difficult menopause situations in comparison to a natural, slowly occurring menopause.
Before we continue with today's episode, I want to give a big thanks to our trusted sponsor, the Better Menopause. I know there are some supplements that aren't suitable for people with a history of cancer, or if you're in specific cancer treatments at the moment, and it can really make us feel like we have even fewer options, like limiting our options. And so I really I'm grateful that I can talk to you about the Better Gut, which is a fantastic product by our fabulous supporters, the Better Menopause. Most women don't realize that gut health and menopause symptoms are so interlinked, and keeping your gut happy and healthy is a foundation for overall health through all stages of life. So the Better Gut is actually not a multivitamin, it's a probiotic, it's a daily capsule, and it's packed with a unique science-backed probiotic blend designed to survive stomach acid and actually reach your gut alive. It can also help you with symptoms like bloating, hot flushes, and anxiety. It's a game changer for lots lot of women in our community. I'm going to link to it in the show notes. And I want to say a huge, huge thank you to the Better Menopause for sponsoring this episode, for supporting our community so that I can get these great conversations out to all of you at home. And then, of course, in general, we haven't spoken about the menopause much. I mean, only in recent years, the last 5 years, people speak about the menopause and different solutions that are out there. And so menopause as a result of cancer treatment also hasn't found its way in patients' pathways. So we know even people who can have their hormones back after some cancers often takes 2 years of self-advocacy, getting referred to different doctors to get their hormones back. So we're kind of like on the back foot in general, aren't we? And then symptoms are more severe. I really want to highlight how difficult it is for people. And you see that in your clinic
It
all the
is.
time, don't you?
Absolutely, Dani. So, as we talked about, the evidence already is so little. The scientific studies or the observational data that exist about menopause management after cancer treatment, may it be non-HRT medication, other therapies, lifestyle modification, hormone replacement, very little to go by. And you often have to depend on little evidence to make decisions, which can be tough for the individual because you often accurately can't counsel how much risk there is or how much benefit there is in the long term. But also for doctors and the health professionals, it is difficult to give accurate figures or accurate results. But also, as you rightly pointed out, the delays. Often it's a late effect of cancer treatment. The focus is on curing cancer initially, and I completely understand that. Nobody wants their cancer back. Everyone wants cured from cancer. And we've made so much good work with cancer treatment now. But after that is over, the late effects often get ignored. There's no support or help for menopause or other late effects that may happen. So women may be left with their GPs. They may be left after oncology treatments end just to themselves to find help for themselves. They may not get the referral to a specialist clinic who deals with late effects of menopause. They may have to look at friends or other colleagues who may be going through a similar situation. And that's where we often don't do justice to menopause after cancer. The long delays, the lack of support continuously comes up as one of the issues when we see them maybe 1.5, 2 years down the line in the clinics, and we need to improve that.
Yeah, I always compare it to sort of lymphedema services. You know, lymphedema also is a long-term chronic side effect of cancer surgery, and we can refer people to lymphedema clinics. Again, there is no cure. We don't have perfect treatments. It's often a condition that needs managing. So it's kind of like not too dissimilar to menopause. Of course, it presents very differently, but I'm really hoping that at one point the referral pathways will be as straightforward for people that are in menopause after cancer as they could be for lymphedema. And I think we can work towards that together for sure. If we talk about systemic hormone therapy, so really explain to us systemic difference to local hormone therapy, can we then look at all of the gynecological cancers and see what evidence do we have? Where is hormone replacement therapy suitable? Where is it contraindicated? Where are you lacking data? So we can give a guide.
Yes. So let's look at the systemic hormone replacement, which is estradiol, which is the estrogen. You have different progestrogens or the progesterone. And then you have, for some women, we also replace testosterone depending on their symptom profile. So systemic HRT means using tablets or gels or capsules or spray patches, and that's all going to the entire body. So the hormones will be delivered to the whole body, unlike the vaginal or local estrogen, which is mainly for vulvovaginal tissues. If we start from top to bottom, the good news is as we've got more and more data in the last 5 or 10 years, we are using HRT for many more cancers than we would have done in the past. So the one thing I want to say is we are progressing. 10 years ago, we would be hesitant to prescribe HRT for many cancers, many type of tumors. That list is becoming smaller and smaller. So we are now able to offer HRT after individualized discussion to many more types or histological types or ways or different stages of tumors. So we'll start looking at the ovarian cancers first. So ovarian cancers, again, these tend to be asymptomatic in the early stages, can often be discovered late. And so there are different types of ovarian cancers. it's important to remember that a significant proportion, up to 30%, can happen premenopausally. So these will be young women having a diagnosis of ovarian cancer who may be plunged into surgical menopause within a matter of days. So for various ovarian cancers, often the treatment is surgery or chemotherapy, and then they are, of course, plunged into medical surgical menopause. Can we offer HRT? The answer is generally yes now. So for different types of tumors that you have, for majority, you can offer systemic estrogen progesterone replacement. There are very few where you have to be careful because there still remain relative contraindications for use of HRT. So which are those? It's usually the low-grade serous tumors or low-grade endometrioid tumors, or sometimes something called granulosa tumors, sex cord stromal tumors. These are some of the histological variants or types of tumors which may be particularly hormone sensitive, and the worry is that hormones may cause increased risk of recurrence. But for large majority of other cancers, whether it's serous, mucinous, and the common types of cancers of ovary, including borderline tumors, usually the agreement now is you can have HRT because the data does suggest that HRT does not increase recurrence and sometimes improves quality of life, and there is reduces mortality for many of these women. So the data are more positive rather than negative. So other than the few I mentioned, most tumors of ovary now we can offer HRT as one of the options.
Okay, so when we recorded, or I recorded, the HRT of the breast cancer series, when the doctors looked at the evidence, some of the evidence and some of the trials and data was sort of conflicting in their outcome. Do you see the same in gynecological cancer studies on the use of HRT, or was it less contradictory and less conflicting? How was it there, the history of it?
Very good question. I don't see as much conflict and problems as we see with the breast cancer. As we've done in the previous podcast, we know observational studies for breast cancer seem promising for HRT, but the old RCTs were the ones that were contradictory and problematic. You don't have that with the gynae cancers. The problem with gynae cancer is overall the studies are so limited. Very, very, very few randomized trials, if at all, with very small numbers. Most of it is small number observational data. So rather than conflicting, I would say most data is reassuring, just that we don't have numbers. We don't have long enough 5-year, 10 years data to confidently say what each individual's risk will be. But the data is definitely neutral or reassuring for majority.
Okay. And do you also see, in terms of oncologists and surgeons, is it also very different to what they would advise a woman? So we see, many opposing opinions in the breast cancer community. For example, do you often see gynecologists saying, absolutely go on HRT after ovarian cancer, and others saying, absolutely not? Is it very much like depending on who you see as well?
I see that less often with gynae cancers. So again, the good news here is that most oncologists will often say, actually, given your subtype, given the histology, given the staging, you may be able to use HRT. Why not I refer you to the person who specializes in the area? So majority of ovarian cancer or other cancer, gynae cancer patients I'll see in my clinic, either the HRT decision has already been made and I'm only getting the patient to choose the right form of HRT, the oncologist has agreed to it, or if it's a very difficult diagnosis like the unusual histology where we don't know much about, then the oncologist writes, can you consider this patient for HRT? I would go by your expert advice. That's great, because that's really why we are existing, to provide the patient the guidance on whether they could use HRT.
So it's a very different conversation to the breast cancer community in a way, isn't it? It's so interesting to understand really how the system works for patients.
I guess it is slightly different though across the country. So because I'm in a tertiary hospital and most cancer patients come to the UCLH cancer clinic where I'll get my referrals from, it may be that the oncologists have already got used to prescribing HRT because we are advocating it. While if somebody has a cancer surgery, maybe in a district hospital or in some tertiary unit where there is no hormone specialist support, they might find it very difficult to get HRT even after a straightforward, well-treated gynae cancer. So I guess it'll be a variation across country, across world, depending on the local setting, but it's getting better. Unlike the breast where there is so much controversy, I think with gynae cancers, other than a very few rare forms of cancer, it's a pro-HRT environment now.
Shall we work down the list? I'm loving this. I'm hoping people at home are really getting their pen and paper out and thinking. This is so much great education. What's next on your list after ovarian cancers?
So we looked at the ovarian cancer, other than the very few I mentioned, straightforward, can use HRT. Let's look at the uterine cancer. Now, uterine cancer or endometrial cancers usually are two types. Type 1, which is well differentiated, hormone sensitive. Type 2, which is less common, is not well differentiated, less hormone sensitive. Overall, most will be treated with surgery, which is removal of the uterus, removal of ovaries and tubes, hysterectomy, bilateral salpingo-oophorectomy, and then some may need further adjunct treatment depending on the stage of the tumor. These tumors are usually have a very high cure rate, very well cured, and majority of women after 1 year will be cured after 1 year of surveillance. We tend to say that because endometrium is a very estrogen receptive tissue, it has lots of estrogen receptors. We tend to say if you're able to start HRT, if you want to start HRT, if you're able to wait 1 year and preferably 2 years, that is when we say start the HRT. And the only reason for that being is that usually any recurrence that happens after treatment of endometrial cancer will happen in the first 24 months. After that, it's very unusual that you will have a recurrence. So let's say if somebody has their treatment and starts HRT very early, then the question is, if they then get a recurrence, sometimes patients regret, why did I start early? Could that have caused a recurrence? While if you wait for the first 12 months, and if possible 24 months, then you're more likely to say it's very unlikely that any recurrence will now happen, and you're more confident with using HRT. That doesn't mean the odd person should keep suffering if they're having symptoms. So we individualize. If somebody really has terrible symptoms which are not responding to lifestyle or non-HRT medication, they may not want to wait 12 months. We do have options where we start estrogen, progesterone very early. And thereby, anybody with severe symptoms, you don't have to follow the 12-month or a 24-month rule. You can have HRT earlier. There are very few endometrial cancer, something called high-risk endometrial cancer type, which have been suggested on some of the guidelines, like the BGCS. I think these will be the ones that to watch out for, if possible, to try all the non-hormonal treatments first before deciding individualized decision for HRT. So that's the only one part of the endometrial cancer. These are the types where you have to be cautious. Otherwise, generally systemic HRT shows good outcomes, no increased recurrence, and actually better quality of life data for whatever evidence we have after endometrial cancer.
Okay, that's very clear. What's next?
Next one is cervix. So cervical tumors, most of them are something called squamous cell carcinomas. And the other one is the adenocarcinoma. Now, majority are squamous cell carcinoma, which means they're not sensitive to hormones. Adenocarcinoma, people have done research and it is not conclusive, but it appears that some adenocarcinomas have hormone receptors and they could be sensitive. So those who have squamous cell carcinoma and cervical cancer is either treated with, if it's early stage, hysterectomy, and then if it's late, then it's going to be a combination of radiation and chemotherapy. And so therefore, in that case, if it's hysterectomy, you can go ahead and give back estrogen or a combination estrogen progesterone treatment. So hormone replacement therapy is completely safe after squamous cell carcinoma of cervix. If it's adenocarcinoma, then there is a little bit of discrepancy. People don't have a consensus here. Most individuals or most guidelines think it is best to try and do all the non-HRT treatments first. And if possible, consider medications like tibolone or progestrogens on their own. That would be the first line. And then if that does not help, if you have to consider estrogen progesterone, that would be on an individualized basis as a last option. Not that you can't do it, But if nothing works, non-HRT, tibolone, or progestogen its own, then decide estrogen, progestogen as an HRT. So it can be offered as a last option. Just to go back to the endometrial tumor quickly, when we do HRT post-endometrial treatment or endometrial cancer, again, we like to give both estrogen and progestogen because progestrogens often suppress any endometrium. So try to make the recurrence chance minimal. We'll often not give estrogen alone. We give estrogen with progestogen, combined HRT.
Even for people that have had a hysterectomy?
Because remember that what the idea is, even if there are some microscopic cells in the pelvis left after a hysterectomy, you want suppressive effect of progestogen, not just estrogen on its own, which can stimulate endometriosis or endometrial tumors.
And when you spoke about the cervical cancer options and there to be no consensus or no real clear consensus, you mentioned tibolone. Can you explain what that is? I don't think it's spoken about a lot. What's tibolone?
So tibolone is a hormone-like compound. It's a steroid which mimics the action of estrogen, progesterone, and testosterone. So it binds to the same receptors that estrogen, progestogen, and testosterone would bind, but it's not on its own a natural hormone. And often that tends to give it a bit of an advantage that it may not stimulate the hormones in the same way as natural hormones would. So tibolone was very popular as HRT, general hormone replacement therapy in the past. The only reason it fell out of popularity was because, one, it's oral. So people with risk factor for thrombosis or blood clotting, they will have a small increased risk of blood clotting. The second one was it has small increased risk of breast cancer, like many other HRT forms. And so it kind of became second-line treatment for general natural menopause. But we use it quite often if there is endometrial tissue, endometriosis, or endometrial cancer or cervical cancer. We still use it as a kind of hormone analog HRT, and it works wonderfully well for many women.
Interesting. Okay. So a good one to consider.
Absolutely. Now, for cervical cancer, to complete, if somebody has not had a hysterectomy and only chemoradiation, so the uterus is still there, they've had a lot of chemoradiation for the cervical cancer, they can be cured, but remember the cervix will be scarred with the radiation. So it often is stenosed. It's a very stenosed cervix, fibrotic sort of scarred cervix. Any HRT after chemoradiation for these women should be combined estrogen progestogen. Because if you give cyclical HRT, the blood will accumulate and not be able to go out of the cervix. And that can cause collection of blood in the uterus. And that is not a nice condition. It's hematometra. Then you'll need drainage of the blood, a procedure for that. So we don't want that. So anybody who's had chemoradiation and is going to use HRT for cervical cancer treatment, always remember continuous combined estrogen progestogen. It's a bleed-free form of HRT, so you don't have any collection of blood.
Okay, amazing. Is the chemo radiation, is that what's called brachytherapy, or is that what it's called?
So chemoradiation is chemotherapy and radiotherapy. And the radiotherapy can be external or internal. The internal is called brachytherapy.
Because so many people in our community have so many issues after that therapy. So we'll talk about vaginal estrogen as well because of that, won't we, in a minute?
Absolutely.
Yeah. Okay, amazing. After cervical cancer is what on our list?
So then we get to vagina and vulva. Much more straightforward because in the sense of HRT, there is no contraindication for systemic or local HRT. The vaginal vulval cancers do not seem to respond to hormones. And so in these situations, one can be using any form of hormone replacement therapy as needed. There's no restriction there.
Okay, wow, that's straightforward. I had no idea. This is incredible to learn about all of the differences. At what point, when you see people in their clinic, how does it work? So in the breast cancer community, I'm just going to compare again. It's often the dry vagina, bleeding upon intercourse, urinary tract infections. A lot of the sexual health related symptoms are very bothersome and they often get treated first. in the gynecologicals of cancer patients that you see, is there a hierarchy to what you would apply first? Would you think systemic HRT first, or would you think local vaginal HRT first, or how would you start a treatment protocol? Or
It's
is
a
it both, if you
it's
can?
it's usually both, so it's a bit of a mixed bag. So the referrals we get, for example, can vary. It could be soon after
Mm.
treatment, it could be up to 6 months after treatment, or 1 or 2 years later. If it's soon after treatment, most referrals happen for systemic symptoms: the hot flushes, the sweats, the cognitive effects, the brain fog, not being able to sleep, anxieties all over the place. And so those sort of systemic symptoms is usually soon after finishing chemo or soon after surgery, up to 6 months. The vaginal symptoms, the dryness, the pain, the bleeding happens a little later. So you've had to have lack of estrogen for a while, and the referrals between 6 to 12 months tend to be both systemic and then vaginal symptoms are predominant. Lots of dryness and problems. And the ones that happen very late because they haven't been referred or not had help from GP or their oncologist, they will have myriad of symptoms. So it will be both systemic, but also lots of vaginal because they haven't had support or estrogen for more than 12 months. Those are the difficult ones because the atrophy, the vulvovaginal atrophy, may have reached a point where it's very severe and it will take time to reverse the changes.
But the hopeful thing here is that you said it can be the reversible changes. That's hopeful that you said it can be reversed.
Yes.
So we know after a lot of the sort of internal radiotherapy, after all of the surgery, a whole load of things can go wrong, right? And just from the surgery alone after gynecological cancers. And then the hormonal effect on top. So the decrease of estrogen, whether that's over a period of time, whether you had surgery that falls off a cliff. Is it advised for these people to actually walk away thinking at one point, I probably need vaginal estrogen? Is that what you see? Do you see most people will
Yes.
probably need some help with local estrogen? Okay, so it's almost an illusion to think you walk away from any of these treatments and
It's
probably
very
never
unlikely.
needing any
Very
help.
unlikely.
Okay.
Yeah.
Okay, so it's important to talk about that. Again, I'm going to refer to the breast cancer community. We talk about non-hormonal options first. So skin-safe vaginal moisturizers and lubricants. Is this also the approach? Or do you think actually we're not going to get very far with the moisturizer?
Well, I think the approach is still non-hormonals first, especially for the high-risk ones. We're less concerned, much more confident now with straight away first-line vaginal estrogen treatment for majority of the tumors I mentioned. It is only the ones that I highlighted in each category, like the ones which are very sensitive to hormones. Say, for example, endometrial cancer has definitely estrogen receptor, adenocarcinoma cervix, then low-grade sort of tumors of ovary, serous kind of tumors. Those are the ones where there is no consensus. They are very hormone sensitive. One would say, why not we try exhaust options like lubricants, non-hormonal moisturizers? Try that first. But it doesn't mean that you have to go on and on with them. The moment you've used them for a reasonable period of 6 to 8 weeks and we realize we're not getting anywhere, vaginal estrogen can still be used because in that case, when the symptoms are significant, your benefits will always outweigh that small theoretical risk with that little tiny dose of vaginal estrogen. So don't wait long even for those tumors. For all others, I
Okay.
think vaginal estrogen can be right up there, front line alongside the first line options.
Okay. So can you highlight exactly where it's a little bit more worrisome to use
Yeah.
vaginal estrogen after which? So let's go through those again.
Again,
Ovarian cancers.
again, let's go through the same
Yeah, can
list.
we
So
do
as we
that,
said with
please? Yeah, yeah.
systemic HRT, ovarian tumors, the ones which are very sensitive are granulosa, low-grade serous, low-grade endometrioid, sex cord stromal tumor. These are ones which are very hormone sensitive. So just like we would avoid systemic HRT, we would avoid vaginal estrogen as first line, but it can be considered on individualized basis if the non-hormonal options do not work. If you look at the uterine cancer, again, it's the endometrial tumors which are the most common. For endometrial cancer, systemic HRT can be used, as we said. We give estrogen and progesterone together for systemic HRT. Vaginal estrogen, we try the non-hormonals first, and then go for vaginal estrogen on an individualized basis. Why? Because once the uterus has been removed, the cancer was right there, and you've now had a leftover vault after the operation where the womb has been removed, and that's called as the vaginal vault where the stitches are following removal of the uterus. Let's say if there was a recurrence going to happen, then those cells would be right close to the vault. And so if you do a vaginal insertion of estrogen, the belief is that it's vaginal, so it could be very close in proximity to the vault of the vagina where the recurrence can happen. That is why we say following endometrial cancer, you would rather actually give a good systemic HRT rather than very local vaginal estrogen. So we wait for all the non-hormonals to work, give systemic HRT, try and minimize the symptom. And after 1 year or 2 years, when we know the recurrence is very unlikely, you can be more liberal with vaginal estrogen. So that's with the
So actually, it's
endometrial
quite.
cancer.
And so for those particular types of individuals, it's probably really helpful to start the systemic HRT
Absolutely.
soon, isn't it?
I
So that
would
you
give
can
that
avoid
preference.
this. Yeah, so that you can avoid for these awful vaginal symptoms to happen, because once they're there, they do need treating.
Yes, absolutely.
That's just, yeah.
Absolutely.
Okay. With cervical cancers,
It's the
you
same.
said it's
So
quite.
just like with systemic, we have squamous cell cancer, no problems. You can offer a vaginal estrogen right up in the beginning. If it's the adenocarcinoma of the cervix, which could be sensitive to estrogen, then again, we try to do non-hormonals first. All the moisturizers, lubricants will be first line. And on an individualized basis, if that's not helping after 6 to 8 weeks, then of course, HRT can be considered as vaginal estrogen pessaries or gel, but that would be the second line option. And for vulval vaginal cancer, no problems at all. You can use vaginal estrogen without any hesitation.
Okay, that's really clear. I want to talk a little bit about more the options when maybe vaginal estrogen isn't an option and isn't advised, and someone is reluctant to try it because of there is no consensus and they worry about that. Is there any evidence that other therapies like lasers, I know maybe they're not used in the NHS widely at the moment, are they going to become a viable option for women, or do you think it's not really out there? And then we also have things like DHEA and intrarosa. So I think these are newer treatments. Can we talk about that a bit?
Yes. So I think if you look at if vaginal estrogen is something that's not being considered, or the woman wishes that she does not want to use it, then of course you've got few options. So let's look at the medical options first, which is the ospemifene, which is an oral tablet for vulvovaginal atrophy. And you've got the DHEA, which is the local pessary. Now, there are no guidelines for use of these medications in cancer patients. They haven't been tried in specific gynae cancer patients. Most guidelines would say don't use it because it's off license. We don't have data about long-term safety. Certainly with ospemifene, it is more or less like estrogen. So one doesn't want to use it. If you're avoiding vaginal estrogen, it's more than going to be likely it will have some estrogen-like action. So we don't often say ospemifene is a good choice. DHEA has been recommended by some guidelines. There is not again a lot of data, but if you would like to consider DHEA, yes, that can be done. It's a pessary to be used every day. It can help with vulvovaginal symptom. The slight trouble is that DHEA eventually acts like estrogen, a bit like androgen, within the vaginal mucosa. So that's the good part of it, is it provides internal vaginal estrogen androgen. The safety aspect we don't know. So again, the question is, if you're avoiding vaginal estrogen, but you're going to be taking a precursor of estrogen, are you happy with that? And if you're happy with that, perhaps yes, you can definitely consider it on off-license basis, knowing that there are not many trials or studies. Laser, unfortunately, I haven't come across a lot of benefit. So I've had few patients who've gone to the private sector to have laser. The problem again is there is short-term relief from many symptoms, but the symptoms come back over time. It tends to be expensive. Each session is quite expensive, and you have to have multiple sessions to keep those effects going. The downsides or problems are few or minimal. Very few reported in literature, appear safe, but nevertheless, because of the short-term gain and quite expensive, I don't recommend laser right now to people.
And it's the accessibility, isn't it?
Yes, it's mainly private sector.
Yeah. Yeah. When you see people in clinic now that come to see you, do you often feel, I wish I had seen them earlier to mitigate some of the risks? Like in an ideal world, like, we have so many people listening to the podcast who are many years on from their cancer diagnosis, but then so many people want to pay the favor forward, really. And there are so many workshops we go to where there is newly diagnosed people. As a word of wisdom from a menopause specialist, would you say get on top of it very soon, speak to a menopause specialist as soon as you can? Or do you think you want to keep it within your oncologist if you can, or gynecological cancer nurse? Because they also play a really big part in
Absolutely.
someone's follow-up, isn't it? What's your experience? How much can sort of a clinical nurse specialist help?
Absolutely. They are the most vital part of this whole sort of puzzle. They're most important piece of this whole puzzle. Now, if I
Okay.
had them in my way, I would want to see these women or patients even before they have their treatment. I would want to
Yeah.
see them at that point, not even after treatment.
Mm.
This is the
Yeah.
time where we often don't talk to them. I know cancer is right there upon the agenda. Many women may not be really thinking about hormones, menopause, fertility, but it does help at that point to have an initial conversation. It helps massively, and many women then realize after treatment is completed, I now realize why that discussion was so important, why it helped me make the right decisions. Now I don't face any delays with getting the help I need. Having a pre-op plan, a pre-treatment plan, even if it's just a simple discussion of what may happen, what to prepare for, what may be your options, and then following up the immediate post-treatment. This is when it would be really nice to then implement that strategy which was
Mm.
discussed before. So seeing them
Mm.
ASAP, that is the key. They're not getting that right now, but as you highlighted, we have to keep working. Seeing them months later or years later, there are some changes that have happened that may not go back. There is also a delayed diagnosis, suffering all the time in the meantime. We don't want that. We want to see them as soon
Yeah.
as possible after their treatment. And as you said, it's the nurse who can play a big role here, because they may not get appointments, they may not get to specialist clinics, but if the nurse can get the plan together in the meantime, and many of them do a fantastic job, they are the key
Yeah.
vital person here.
Yeah. Okay. Thank you. That was a really clear answer, actually. It goes way before treatment. It goes to that point when we consent, right? As a patient, we consent to the treatment. You sign on the dotted line for chemotherapy. We hear it all the time from patients saying, I knew it was going to impact my fertility, but I actually didn't know that was the menopause. So often as a patient, we're so ill-informed about a woman's biology. I know we're women, but we know very little often embarking into life. We know puberty, and we know very little about menopause, and often people say, I knew it was going to mess with my fertility, but I didn't know that was also the menopause. And so it's important to put the right words to
Yes,
the right symptoms, so
yes.
we don't think it's just us. We know this is actually a thing, and it will most likely happen to us. This was so informative. I have so many more questions, but I feel like it would be really good to leave it there.
Just
Do you
one more,
think as
Dani,
well?
before we finish.
Yeah,
You're
yeah.
absolutely right. So we haven't talked about only one bit of rare tumors because they're not sort of
Ah,
kind of common. So the sarcomas.
okay.
So very rarely some
Ah,
women may get diagnosed with uterine sarcomas. These are sarcomas or
okay.
malignancy that comes in fibroids, leiomyosarcoma, or they may have something called
Hmm.
endometrial stromal or undifferentiated sarcoma. These are from the muscle
Okay.
of the womb rather than the lining, which is the endometrium. So if sarcomas happen, they're an absolute contraindication for hormones. Fortunately, these tumors are extremely rare, don't happen commonly, but my heart goes out to people who have them because these are very sensitive to hormones. They're certainly the ones where hormones can cause a high chance of recurrence. So we often advise not to take hormones, and you can have all other non-hormonal treatments, as many as possible, including in future, hopefully we'll have the NK3 receptor antagonists who might play a big role in this population of patients where they can't have hormones. Some of these women may be able to take progestogen on its own, but again, these are things which need individualized decision making. But I brought up that point because you may have somebody in your
Mm,
community who may have had these
mm,
rare tumors and may find it even more difficult to get the right support.
mm. It's so important to address everyone in this community, isn't it?
Yes.
And to finish on that note, so if a person finds themselves in this group, for example, which, you know, a lot of the breast cancer community is in, you have so many other strategies, right? I know the success rate very much depends on the different patients react to different treatments. But what else, when I come and see a menopause specialist, might I be able to walk away from if it's not HRT or local estrogen? So what other things can you do for us?
Absolutely. And Dani, I think you are the best advocate for all of these rather than me. You probably have much more experience with all these alternative forms of treatment which help patients. But just to say, it's not all about HRT. I have lots of women, even after cancer, who have taken a decision not to take HRT or have been fortunate enough not to suffer from the worst symptoms. So they've stayed away from HRT. There are lifestyle intervention, healthy lifestyle, alternative therapies, CBT, the new non-hormonal therapies such as the NK3. There are antidepressants which do have a role in some patients. There are oxybutynin, clonidine, gabapentin, not commonly used, but specific patients with typical medical history or scenarios can benefit from some of these non-hormonal medications. Remember also local treatments, whether it's dilatation of vagina, whether it's giving the moisturizers, lubricants, whether it's pelvic physiotherapy for bladder or post-radiation vaginal bowel issues. All that is holistic care in addition to the hormones that we provide. So there are plenty of things to think about. Having that initial consultation is basically food for thought. After you've had cancer, a
Yeah,
difficult menopause, that initial
yeah.
consultation with a specialist or even a GP who's well trained in menopause, that will give you the options you have. Then it's a matter of taking a step back, looking what fits for you individually, what are the benefits, risk, particularly in your situation, which may be different from others, and then coming to a decision, I will do this, then a follow up. That would be an ideal care pathway to get things right.
Thank you. So, in the last couple of months, we put together a menopause symptom checker on the Menopause and Cancer website, and we listed all of the sort of symptoms, whether they're physical or mental, and we divvied them out into symptoms down below, we called them. So all of our vaginal symptoms, and we did a GSM symptoms. We just made it very separate so people know it's just more than a dry vagina. Would you find it's helpful when people came really knowing what their symptoms are when they come into a consultation? Do you think it's worth sharing that maybe in the show notes so people really know what they're talking about when they have an appointment?
Absolutely. It will be a huge time saver for both for patient and the doctor or the nurse, because if you come prepared with your symptoms, in fact, sometimes even tracked over 2 to 3 months, you can track them, see how they are worsening, getting better, or the same. If you have 2 or 3 checklists like that over 2, 3 months and bring them to the consultation, it's a massive help because sometimes it's difficult to remember everything within those 20, 30, 40 minutes. So also for the doctors to go through the whole checklist, if they have a visual aid that they can see what you've gone through, that just starts the consultation on a good note.
Okay, we'll share that in the show notes as well. Lots and lots of questions I've got in my head, but I'm going to keep my mouth shut, zip here, and we're going to continue the conversation. And I'll also bring some patients in from the gynecological cancer community who could really talk about their experiences, that others benefit from that shared experience, which is initially what it is. That aim of mine to connect you experts with the community is continuously growing stronger and stronger, because there are so many amazing experts like you with that really laser focus and that knowledge, and it's getting that out and elevating and giving that microphone almost, and then it's hearing patients, because every time I learn something new, as I'm sure you do as well, isn't it, when every
Absolutely.
patient, you often write that on your social media post, how much you learn from the patients in your clinic. I love reading those. So thank you for all of the updates.
Thank you, Dani, for doing everything that you do.
Thank you. And thank you everyone for listening to today's conversation. I hope this episode was helpful to you. I know it's a super practical episode. We didn't really go into any of the emotional difficulties that come with having any type of cancer diagnosis. And then, of course, living with the daily effects of that cancer treatment, may it be a lymphedema, may it be the menopause. And so I never want to underestimate that. But today's episode was really very much meant to be a very practical episode. And I hope many of you feel reassured by the options that Mr. Talaulikar explained. And some of you might be feeling, I'm not quite sure, maybe you've heard something different, maybe you've had no guidance, and where do you go with that? Sometimes we hear different opinions from doctors. And so it's really important that we all go back to our team and our doctors and our clinical nurse specialists and our GP to get the ball rolling if perhaps you think your menopause after your gynecological cancer diagnosis hasn't been addressed adequately enough. You do know if you're in the UK, you have access to see a menopause specialist like Vikram on the national health system. Your GP can refer you, but also your clinical nurse specialist or your oncologist. I know the waiting list is really long, but in the meantime, perhaps you can work with your GP, general practitioner. I don't really know exactly how it works in other parts of the world. I just know we need to talk about it a lot more. And we need to amplify voices like those of Vikram's and to really get the message out there, what help is available to who, because I think when we're not all very much informed about what our options are, it often paralyzes us and people don't do anything. And then the suffering goes on behind closed doors. So it's really important to look at those options and to find a clinician that can work with you on providing the right support. With that, I'm going to love and leave you. I can't thank Mr. Talaulikar enough for his continued support. It's amazing to have the support from so many experts. I feel as a patient's advocate that it's really a part of my job is to listen to you and everyone out there. And I've really made it my mission to listen so that I can learn from you, so that I know what's going on in your life. So I've got my own experience, but that doesn't mean much in the grand scheme of things. I really want to hear from you and then also bring together the experts and share their voices and share their expertise with you. And I hope that comes through in all of our episodes. Anyway, I'll see you on the podcast next week, and I hope for the right people, today's episode was exactly what I needed to hear.